Hello, everyone. Good morning. How are you today? My name is Janine Guglielmino. I'm the Director of Programs at Living Beyond Breast Cancer, and I'm so pleased to welcome you to the plenary session, Metastatic Breast Cancer Treatment Strategies with Dr. Cliff Hudis, and to welcome you all to our annual fall conference, Breast Cancer Today, Individual Treatment Shared Experiences. So today, at this plenary session, we're very fortunate to have Dr. Hudis, and he's going to be talking about the treatments that we use to manage metastatic disease. And as you know, this year we have a tracked system where we're talking about the different diagnoses subtypes. But in this session, Dr. Hudis will address all of the subtypes. So there'll be something for everyone, no matter what your situation. So he'll be discussing the factors that might influence your treatment options, talking a little bit about treatment goals, and what future directions of care could be, so some research highlights. The way this session will work, we are audio recording and we are also web streaming so that folks outside the room can share in today's remarks. So I hope you'll welcome our web stream folks. We did lose a few attendees because of the situation in Chicago, so we're very fortunate to be able to have the web streaming today. After Dr. Hudis' presentation, we will take questions. We're going to put a number up so you can text your questions. It's a little bit easier than running around the room. If you're unable to text, we will find a way of getting your questions for you. And just one little piece of housekeeping, if you need a ladies' room or a men's room, the bathrooms are down the hall and to the left. So just a couple words about Dr. Hudis. He is the chief of the Breast Cancer Medicine Service and attending physician at Memorial Sloan Kettering Cancer Center in New York City, where he is a professor of medicine at Weill Medical College of Cornell University. He is also the immediate past president of the American Society of Clinical Oncology. His research interests include developing medicines with a focus on integrating new agents into the treatment plan. And last but certainly not least, Dr. Hudis is a member of our medical advisory board and speaks for us frequently. So without further ado, I'd like to introduce Dr. Hudis.
Thanks very much. It is a treat, really, and an honor always for me to come and join everybody here. So I'm going to give you kind of a cook's tour, I guess, of systemic therapy options for metastatic breast cancer. Both some of the promise and honestly some of the warts and some of the issues to watch out for. Just by way of introduction, I'll point out that on the one hand, the science has never been more exciting and the therapeutic options that we have never broader and honestly never better. At the same time, for lots of complex reasons, we as a community are starting to look at the big societal issues of cost, value, and so forth. And we need to take charge of that together, or solutions to the perceived problems will be imposed upon us by others. So occasionally I'll make some comments about relative benefit and value and what it really means. I'm going to talk following this outline. So epidemiology and natural history of metastatic breast cancer, I'll describe that for a minute, although I know many of you are familiar. We'll talk about the real goals of therapy, and this is sobering occasionally for some people, but I hope that your doctors are honest and forthright with you so that you can be really good partners to make the best decisions for yourselves. And that requires some occasionally difficult discussions about what it is that we're trying to actually do in this setting. And then, as you heard, by subtype, what we say phenotype, we will talk about the three broad areas of therapeutic development: hormone therapies, cytotoxic chemotherapy, and the anti-HER2 drugs. So epidemiology, natural history, this is about what we face in the US this year. It's interesting, there's a disconnect between the US and the rest of the world. In the United States, breast cancer is the most common, potentially life-threatening cancer, but it is far from the most common cause of cancer death. Lung cancer, for example, is a much more frequent cause of death than breast cancer. I corrected a paper that came from one of our surgeons recently, and I was embarrassed because the paper said that breast cancer is the most common solid tumor cause of death in the world, and I thought that wasn't true. It is true. Outside of the US, where access to care is so much more limited and many, many more patients present with advanced disease, it actually is the leading cause of cancer death in the world outside of the US. One of those sobering points to bear in mind is that there are 300 and X million Americans and 7 billion more or less people on Earth. So the American experience is less than 5% of the experience on Earth when you think about the relative role we play in terms of population. So we do much better in the US. There are about 50,000 people, maybe 60, somewhere in that range, who are actually diagnosed with metastatic breast cancer in the US alone each year. But the deaths attributed to metastatic breast cancer are around 40,000, and they've been dropping every year since 1990. And the disconnect there is that some people have, if you will, the good fortune to die of something else when they have metastatic breast cancer. It sounds glib, but it's exactly like prostate cancer. So I frequently use this example because the issues are really quite the same. Virtually any 95-year-old man has prostate cancer. You almost can't find an exception to that. Every single man gets it if they live long enough. The chance of being 100 with a prostate and without prostate cancer is about 1%. So what that reminds you of is the somewhat symbiotic relationship we have with aging, the development of cancer, and the possibility of lower grade cancers. Those men do not die of prostate cancer, they die with it. And some people with breast cancer, especially historically hormone receptor positive in older patients, but increasingly the HER2 positives even, honestly live long enough to die of something else, but they do die with it. And this begs all those challenging questions about what is cure and what does that mean versus what is survival and so forth. I don't want to spend overly much time on that, but I do want to point out that that's why we can say that metastatic breast cancer is treatable even if it's not curable. The median survival, and this is a hard number, is 2 to 3 years after the diagnosis of metastases, but, giant but, the range of outcomes is extraordinary. I have a patient of mine who I've treated since the day I went into practice, and when she meets one of my fellows, she says that her breast cancer is older than they are. She loves saying that to them. And it's true, because she was diagnosed with metastatic disease in the early 80s, and my fellows were born in the mid-80s. So it's true. And as I said, the mortality's been dropping since 1990. One of the reasons, it's not the only reason, is the increased number of drugs, some of which were simply in the market and used. Others are actually FDA approved. And you can see, these early chemotherapy drugs from the 80s, in most cases, did not have specific labels from the FDA for breast cancer. If a drug was approved for cancer, it was used. More recently, we've developed in an era of science more targeted and much more expensive therapies. And with that, we have very narrow approval labels. For example, TDM1 at the bottom here, which is a HER2 targeted drug, has a very specific indication, and you really have a hard time getting it in most cases outside of that. That is not the way cancer treatment was through the 1980s and 90s. Now I'm going to start with my provocative comments. The number one correlate of the price of a new drug is A, efficacy. Who thinks that's a correlate? B, cost of development. Who thinks that's it? Yeah. The answer is C, year of introduction. That's it. Forbes magazine, Peter Bach. You can take a look at it. So we have a structural problem that is going to come and represent a challenge in drug development going ahead. So these new drugs that have been introduced are all very, very expensive. They have very narrow markets. That's one of the defenses used for their high price. But it looks like, at least at a first pass, that the number one predictor of their cost is just the year they came into being. Now, they are making things better. This is a single series from MD Anderson, Sharon Giordano, and you can see from 1974 to 79 at the bottom versus 1995 to 2000 at the top. This is a so-called Kaplan-Meier plot. For those of you who aren't in the sciences, the way you read this is very simple. You look at the x-axis, which is months from diagnosis. You look at the y-axis, which is how many people are still alive, and it's better to be higher than lower. And so you can see that within one institution over 2 decades, the survival for breast cancer incrementally improved. This is very much, by the way, the story of acute leukemia in children. You know, in acute leukemia in young children, there was never actually a breakthrough. There was no transformative drug that came along, and most of the treatments today are more or less the same treatments that were available 20 years ago. What happened was incremental improvements using the available drugs in a smarter way over time, and of course enrollment in clinical trials. So 90+% of kids with leukemia are treated on research studies. You know, obviously less than 10% of adults with any cancers are treated on trials, and that slows down the pace of advancement. But it's the same kind of an incremental curve with acute leukemia, and that gives us hope and optimism because we got pretty far just by optimizing the available agents. And in breast cancer, we've had the benefit of adding on many new drugs as well, as I mentioned. So I want to talk now a little bit about goals of therapy, and I alluded to this a little bit. Cure really is our goal, but cure is elusive for metastatic disease right now. It's not something that, honestly, physicians should be presenting as the reason to get treated. I'm not saying that there aren't the occasional anecdotes of somebody whose cancer completely disappeared and gives the appearance of cure. That's an extreme outlier response. It does happen, but it's not the primary reason to go through treatment. If you think that, unfortunately, you'll be disappointed, and you might do things that are harmful. Prolonged survival. Well, I just showed you we can do that, and we are doing that every day. It doesn't mean that there's a single best way to do it, but that's the primary goal of treatment. Then we get into something that's supposed to be a surrogate for that, prolonged time for progression. And this even came up yesterday. Roche published in one of the lay press a comment about the use of bevacizumab, Avastin, and capecitabine, where they said that it was associated with prolonged survival before the cancer got worse. And what they're highlighting there is that most people would perceive that it's better to live longer before the next thing happens than shorter, and I don't disagree. However, you do need to be well aware of the fact that the relationship between that benefit and actually living longer is tenuous at best, and in fact largely does not hold up. We all hoped that progression-free survival, time until the cancer gets worse, would be a predictor of overall survival, and that's why the FDA has in part used it to approve drugs. However, it has not worked out as consistently as you might think, and so there are many, many examples of drugs that help you go longer on that first treatment but don't seem to contribute in the long term. This is not meant to be a downer. It's meant to say that we need to aim higher and develop better treatments and not rely all the time on these surrogates. Fundamentally, and the word has a bad association, I wish it didn't, what we're doing with metastatic disease is palliating from the first day. And it's a good word. The idea is we are limiting, delaying, preventing the development of symptoms and signs of the disease so that our patients can live normal day-to-day lives for as long as possible. That is the goal, and that is palliation, and we should be having that conversation honestly and openly from the first day. If we do, then we understand why we don't want to just do everything to make people sick. We want to limit toxicity. We want to give the right amount of treatment at the right time to the right patients for maximal benefit. But we also want to stay out of people's way. We want you to go to work. We want you to take vacations and enjoy life and not just be living in a doctor's office all the time. So I said I wanted to focus next on treatment options, and this will feed into the goals of therapy. There are, as you know, at least from a clinical point of view, 3 subtypes of breast cancer. The truth is there are many more as we use increasingly sophisticated tools. But in any clinical office in the United States in 2014, you can determine if the cancer is HER2 positive or not, and if it is estrogen receptor positive or not. And if it's one or the other or both, you use directed therapies for those things. And if it is none of those things, it is labeled triple negative, the triple being ER and PR for hormones and HER2. But as I frequently point out, if I don't live in California and I don't live in New York, it really does not make me a Pennsylvanian. I could be a lot of things. And triple negative right now is, unfortunately, that. It is not ER and PR, and it is not HER2, so we say it's triple negative. But I'll show you. There is no doubt that triple negative represents a constellation, a collection of diseases, plural. Then there are other factors that doctors should be using when they make treatment decisions. How long has it been since the first diagnosis until the cancer came back? What specific sites have been involved, the pace of development, and so forth. So I'll give you the classic anecdote. As a physician, you see a patient who had breast cancer in 1989, shows up in your office with no records except a piece of paper that says it was breast cancer, and you are presented with her now decades later with bone pain, a positive bone scan, and a biopsy that reveals adenocarcinoma. That means gland-forming cancer, and you don't have any markers on it at all. At first you say, well, what am I supposed to do with that? What the skilled physician says is, well, that's a long disease-free interval, that's a bone-dominant recurrence, that smells like hormone receptor positive breast cancer, so I'll just empirically try it. And even when the receptors come back negative, you do that. You know, the natural history is an important part of this. The converse, somebody with an estrogen receptor positive breast cancer who reappears in your office with a organ involvement, a liver or lung at the 11th month after treatment. It may be estrogen receptor positive, but your optimism about it being hormone sensitive is down because of the short interval. Those are the kinds of basic natural history facts that we always want to take into account. So hormone therapies. This is actually, you know, an interesting story, and not everybody knows this, but actually endocrine treatment, hormone treatment for breast cancer, in most ways defines medical oncology. The very first demonstration that there was a possibility of really using drugs, and I'm not talking about Dr. John's, you know, medicine pills from the Civil War, I'm talking about real treatments, was probably a Scottish surgeon named Beatson. Beatson liked to take the ovaries out of sheep and see the impact on their endocrine activity, and then he did it in women. And in the Lancet, Volume 1, 1896, he published a series of women who had their ovaries removed as treatment for breast cancer. Now, in those days, long before mammography, the way that breast cancer presented clinically was a palpable lump, and unfortunately, the chief complaint of many patients was, I smell bad, the skin was infected. That's just how it was. And they lived in asylums and often were cared for by other members of their community who also had cancer. So Beatson took out ovaries because he knew that only women largely got breast cancer and women had ovaries, and he made that empiric connection. And some of the time, the cancers got markedly smaller, enough that he could publish this. It wouldn't pass muster even as a phase 2 study in 2014 because supposedly he didn't report on all the patients, and of course he had no ability to select who had triple negative cancer, who had HER2 cancer, and who really had hormone sensitive disease. But some of them responded. And that meant that in a narrow way, a systemic hormonal therapy could influence cancer. And that's why I actually think long before the Bay of Naples and the chemotherapy development, this really marks the beginning of systemic treatment for cancer. In 1944, Hudis actually synthesized estrogen, which was used to treat cancer, just like it's blocking it is used to treat cancer. Patterson did the first randomized clinical trial in breast cancer and really any solid tumor that demonstrated benefit. This is the beginning of a modern era of clinical research. He took the ovaries out of half of the patients by random assignment and demonstrated that those without ovaries did better. And then Huggins actually went on to win the Nobel Peace Prize in 1966 in medicine for the development of endocrine therapy directed at prostate and breast, given their similarities. But this was largely because of another surgical procedure. They took the adrenal glands out in postmenopausal women, and that's a source of the endocrine precursors. So if you take them out, you don't have the androstenedione, and you don't make testosterone, and you can't make estrogen. So that's the backstory on hormone therapy. Actually, Craig Jordan then went on to largely lead the development of tamoxifen. He was here in Philadelphia for years at Fox Chase. And tamoxifen, which is a selective estrogen receptor modulator, or SERM, became the de facto standard hormone therapy for breast cancer for many, many years. Widely misunderstood drug. It's more estrogen than not. even though everybody calls it an anti-estrogen. Virtually all of its side effects, apart from hot flashes, are as if you were taking estrogen. It thickens the uterus, it causes blood clots, it's good for bone density. Those are all estrogen effects. And I mention that just to remind everybody that we're not as smart as we think we are, and we actually can treat breast cancer with Premarin on occasion, and we do sometimes. In a simple sense, anything that we do that disturbs the hormonal milieu of ER-positive breast cancer seems to cause it to die for a little while before it develops resistant mechanisms and grows again. And that means we can starve it for estrogen by taking the ovaries out. We can further starve it with aromatase inhibitors. We can feed it with tamoxifen. We can feed it with estrogen. Each time we perturb it, it's like you poke it, you get a little bit of a response. The specific choices vary a little bit by menopausal status, although this is increasingly coming together, and especially in metastatic disease, we largely reach menopause quickly in such patients, either chemically or surgically. And once we do that, then the treatment options are all the same. The simple concept is we give them sequentially, one after the other, try to eke out as long a time as we can with each treatment. I stuck this in just to say that we continue to tweak even this. This is fulvestrant, the most recently introduced hormone therapy for breast cancer. This is a so-called SERD, a selective estrogen receptor downregulator. It also binds to, attaches to the estrogen receptor and temporarily destroys it. One of the marketing pitches is that it destroys the receptor. It must be great, and that would be great, except that destruction lasts hours. So the cells make it again, and they're constantly replacing it. And that's part of the reason that it's not a perfect treatment. But what you can see is dose matters. The yellow is the higher dose, and the proportion of patients benefiting with the higher dose was greater. And indeed, about 3, 4, or 5 years ago, I can't remember, the higher dose became standard. One of the areas where science is really paying off is in the old area of hormone therapy for breast cancer, because we are discovering with both cell line data and animal data, as well as bioinformatics, these fascinating Rube Goldberg kind of pathways by which cells communicate. This is something most people on Earth never really have to think about, but a cell, of course, has a membrane, which is like the surface of a balloon. It has its inner contents, and messages have to be transmitted from cell to cell. So to be very simplistic about it, when estrogen is floating by in your bloodstream, it doesn't just make cells grow, it physically attaches to something, the estrogen receptor. Then something has to happen. It's kind of like a Rube Goldberg thing with the ball falls and the lever falls and so forth and so on, eventually telling the cell to do several fundamental things. One, don't die. Two, divide and grow. Those are the big categories of things, right? And the way those messages are transmitted is complex, interconnected, and there are other components of it that we're beginning to explore. So for example, mTOR, which is shown in yellow here, this is the mammalian target of rapamycin. Rapamycin is a drug. It's actually used for immunosuppression. This is a funny way to name a molecule because it's named by its function, but once you know what it is, it makes sense. So everolimus, which is one of the mTOR inhibitors, has been developed, and it basically, by inhibiting mTOR, would block a downstream signal from these pathways that interacts with the signal from estrogen. If I've already lost you, I apologize. The simple concept is that 1 + 1 should give you 2.5 or 3. So you're blocking the pathway, the signaling to the cells, 2 different ways. And this is the randomized trial of everolimus or a placebo. So half the people got everolimus and half got a placebo. Everybody also got letrozole, the aromatase inhibitor. So this is metastatic breast cancer. Everybody on the research study is getting at least standard therapy. Half of the people were getting additional treatment. This is a result that illustrates, in a nutshell, many of the concepts that I was touching on before. You can see the curves in each case. This is the local doctor's assessment, and this is the Central Review Committee's assessment. It's about the same. Everolimus was clearly associated with an improved outcome on this upper curve versus the placebo, given with, I'm sorry, I said letrozole, I meant exemestane. Doesn't matter though. So at first blush, strikingly positive result published in the New England Journal of Medicine. So the question you have to ask immediately is, does this change practice? Should everybody therefore get this? And to answer that question, you have to drill down a little deeper. And your first question is, okay, they lived longer before their cancer got worse, but did they live longer? And the answer to today is no. And this is frustrating and disappointing. 2, was this expensive or cheap? You can guess the result there. 3, was it toxic or a free ride? And the truth is, it's mostly okay, but it has some new toxicities, mouth sores, pneumonitis, which means inflammation, not infection, inflammation in the lungs, occasionally requiring intensive care unit treatment. And so you can see that what we have here is a drug that's clearly biologically active, might be important, is not saving lives, is toxic and expensive. And right there is kind of a nutshell for a lot of the kinds of developments that we see these days, which is to say it's better, but we don't quite know yet how to optimally use it. This is the example of the toxicities, which I won't belabor, but you can see that mouth sores occur in more than half of the patients who get everolimus, 10% on the placebo. Fatigue was a little bit greater, shortness of breath was greater, and the pneumonitis I alluded to, 12% versus 0. So there's a price to be paid. There are other trials that find the same thing. This is tamoxifen with the same mTOR inhibitor, same kind of a result. So these drugs are here to stay. Everolimus is FDA approved. There may be other mTOR inhibitors. There are other drugs targeting the pathway. Indirectly, this is related to the whole PI3 kinase inhibitor story that you hear so much about right now. But the challenges are the same. These drugs are new, they're expensive, it takes a lot to develop them. They clearly are biologically active and they matter. But our job is to optimize their use so that not that every patient needs to get another $100,000 drug, but that the subset get them where it makes a big difference. And you yourselves, everybody in our community has to be honest about what these endpoints mean. If the disease is stable for a longer time before it gets worse, but death occurs at the same date as it was predetermined to occur, you have to ask yourself, is this a benefit that's really worth it or not? And what I'm really saying is a surrogate endpoint of progression-free survival the end-all and the be-all. And it's a little provocative what I say. This is something that came very much to a head in the bevacizumab discussions a few years ago, but the issue is still here before us. Chemotherapy. So this is just another example of the improvement over time. This is the British Columbia experience from Steve Chia, and you can see that over time there's been a gradual, just in the 90s, incremental improvement in outcomes for people who got chemotherapy. Part of it's because there's so many drugs. This again highlights, though, one of the challenges we face. Some of these drugs, in indirect comparison, look better than others, and you can see, for example, a wide range of response rate. How often did the cancer shrink by a predetermined amount? A low of about, 25%, a high of about 42%. But you'll notice the time until cancer got worse varies, and the overall survival varies as well, but not necessarily in accord with the response rate. I only say this to say, again, all these drugs are active, but there is no clear winner, and it is not yet established that a surrogate like response rate or time to progression does the job. What we care about, in my opinion, is overall survival. Should we give drugs together, chemotherapy drugs, or singly? And this has been an area of controversy recently solved or settled to some degree. The historic reason for this goes back to the 1960s and 70s. At the National Cancer Institute in the early days of chemotherapy, when these new drugs were coming along, Vince DeVita famously combined chemotherapy drugs using a mustard gas derivative to make MOP, M-O-P-P, combination chemotherapy for Hodgkin disease. And in the 60s, he reported in phase 2 originally that young people with Hodgkin disease, heretofore fatal in the short term, were suddenly seemingly cured. It was such a shocking result that, and this is not just lore, it's the fact that our own community didn't believe his results at first because it was that different. But it turned out to be true. And that led then to the so-called CHOP, C-H-O-P, chemotherapy for non-Hodgkin's lymphomas. And then the platinums came along in the 1970s. That's what cured testes cancer. Again, a combination of drugs. So the mantra was, combinations of chemotherapy are the answer to cure cancer. The problem was that non-Hodgkin's, Hodgkin's, and testes cancer might have been the exceptions rather than the rule. And the results seen there were very different from the results in most solid tumors. So what happened with breast cancer is CMF was developed, Cytoxan, that's cyclophosphamide, methotrexate, fluorouracil, and it was an empirically developed regimen. It wasn't based on laboratory science or preclinical work. It was just drugs could be given together safely, and they worked, but maybe that was or was not the optimal way to do it. And in the metastatic setting, the optimism was if we just combine enough drugs together, we'll come up with all these drugs with non-overlapping side effects and non-overlapping mechanisms of activity, and we'll cure a bunch of people. And that just sadly didn't turn out to be true. Harkening back to my comment about palliation, we then turned the question around in the 1990s and began to ask, well, instead of giving all these drugs together, maybe we should just give one drug at a time until it fails. And by the way, you know, patients never fail treatment. Treatment fails patients. That's a semantic bug that always catches me. So until the treatment fails, and then give the next one. And what this busy slide tells you is that we were right, that giving combinations of therapy gets you a higher response rate. It gets you a longer time for the first treatment failure, but it doesn't actually get you anything long-term that you wouldn't get if you just sequentially gave one after the other. And this is a really bitter pill to swallow. I saw a patient with new metastatic disease on Wednesday, and she really couldn't understand why I wasn't giving her 3 chemotherapy drugs and her hormone therapy all at once. You know, it's a hard concept to get across at first, that we're going to take our time and not make you sick and treat you for a long time with gentle therapy, and it's just as good. More recent drug development, and this is a little bit of a reason for caution, has been built on the idea that combinations are better, but sometimes this leads to a waste of time. This is a new antimicrotubule drug, ixabibolone, was FDA approved a few years ago based on this study and another one, and this is a sobering result. This is capecitabine or Xeloda, the brand name drug alone, or with the second chemotherapy drug added. You can see that there's a difference in the curves, but look at the median time till disease progression. It was 4.2 months with capecitabine, and it was 5.8 with the combination. So you can ask the objective science question, is ixabibolone active? Yes. But then you can ask the subjective question, is it worth it? Is a 6-week difference in the time until the cancer gets worse really worth it? So they got approved, but the drug really didn't make it very well in the marketplace. In contrast, this is the study of a halocondrin B analog, eribulin, done in a pretty open and interesting way. They randomized patients to receive the experimental chemotherapy drug, eribulin, or any of about 5 different standard options that doctors could give. My comments 5 minutes ago, all these drugs are about the same. They put it into practice. They didn't stipulate the control arm. They said, doc, you can do whatever you think is best. We're brave enough to go against that. And the primary endpoint of this study wasn't time till disease progression or progression-free survival. It was overall survival. Do people live longer? And the study turned out to be positive. Not dramatically, but it's one of the few where there was a detectable difference. The people who got eribulin lived longer than the people who didn't. So for me, that's a transformative observation. It suggests, A, it's possible to improve survival, and B, we ought to be aiming for that when we conduct our clinical trials, because the value discussion is a whole lot easier when you're talking about survival than when you're not, in my opinion. Now, we have to keep doing these studies. This is a study we did in the Cancer and Leukemia Group B, now called the Alliance. Hope Rugo from UCSF was our PI. And what we did here is compare standard cheap generic chemotherapy, paclitaxel, against expensive new chemotherapy, NAB, that's albumin-bound paclitaxel, brand name Abraxane, and that ixabibolone that I just showed you. Ignore the bevacizumab for now. The reason this was important was so much marketing was hyping these new drugs. This is the bottom line here. The blue line is paclitaxel, the green line is the NAB paclitaxel, and the red line is the ixabibolone. So these new and very expensive agents did not outperform, and that's being gentle, paclitaxel. They underperformed it, actually. And we reported that and have a manuscript in press, hopefully a little later in this year. So we have to continue to study these, and we have to be very, very dogmatic about defining benefit and making sure we actually achieve it. So I want to focus on this question I hinted at earlier about whether triple-negative disease is truly distinct. Biologically, it is. You don't have to worry about this slide except to say that some of the triple-negative breast cancers harbor a defect in their DNA repair that makes them look a little bit like BRCA-associated breast cancers. And for that reason, not only might they be candidates for PARP inhibitors, which are the sort of drug of the moment, but also maybe candidates for platinum-based chemotherapy. I caution you in that regard. There have been a large number of studies of platinums for triple-negative breast cancer. The meta-analysis for the non-BRCA-associated cancers is that they don't really show anything. And that's what this slide says. So your doctors will continually bring up the potential of platinum for triple-negative breast cancer. My caution to you is not that you should avoid it. I think it's a fine choice. It's just that it's not different or better than the many other chemotherapy treatments at the moment there. This is another way of looking at this question about whether it's really one disease or not. This is from the so-called TCGA, which is published in Nature 2012. This was the deep genomic sequencing of triple-negative breast cancers. And the interesting thing is, when you look at it, some of the triple-negative breast cancers actually, by genomic analysis, look like luminal A, that's hormone-sensitive breast cancer. And some of them look like HER2, although the vast majority have the basal-like type. It just makes this nuanced point that everything isn't identical. When we look at it in another way, this is another way of subtyping the triple-negative breast cancers. We see that response rates to specific agents can vary. This is work from Vanderbilt showing the same thing. And I'm not here to belabor this. I'm just trying to make the point that triple-negative is heterogeneous. One of the areas that we've had some success recently has been in identifying a subset of triple-negative breast cancers who could be treated with hormone therapy. That's a jarring concept at first. It makes no sense. The reason is that about 10% of triple-negative breast cancers actually make the androgen receptor, not estrogen or progesterone, but androgen. And we proved preclinically that androgen was driving them, that we could block androgen and kill them. And so we conducted a clinical trial with an old generic prostate cancer drug, bicalutamide, also known as Casodex. And in that study, we got about a 20% benefit rate. It's not a game changer. But what it means is that for some people with triple-negative breast cancer, if we stain the tumor and find the androgen receptor, we can offer a cheap, generic oral therapy for some months or longer, in some cases years, where their quality of life will be immeasurably better than while they're on chemotherapy. So this is something that we do advocate, testing for the androgen receptor in consideration of this. I alluded a moment ago to the idea of the PARP inhibitors. I'm not going to say much about it, only because they're still in development and they have been for a while. But the simple concept is that BRCA, BRCA 1 and 2, are key components of normal DNA repair. You need them to be functioning normally to fix the everyday damage that we all acquire. Walking from the train station in the sunlight, you're hit by UV light. You're always picking up in the environment DNA damage. This is not a reason to be afraid of the world. This is just the way the world is. And we fix this over and over again 1 billion times a day. But if you have a BRCA defect, one of your redundant DNA pathways, repair pathways, is damaged, and you're dependent, therefore, on the others. What the PARP inhibitors take advantage of is that dependency. They inhibit a second DNA repair pathway. So they're pulling a second leg out of the three-legged stool, if you will. And the cells that are more sensitive to that are the malignant cells, and that's what we're hoping to see develop. For the last couple of minutes, I want to talk about HER2, obviously an area of great advance in the last few years. This is the family. A lot of people don't know so much about it. HER stands for human epidermal growth factor receptor, HER. There are 4 members of the family. HER1 is a synonym for EGFR, the epidermal growth factor receptor. Everybody knows that because ultimately that's the target of the controversial drug Trastuzumab from ImClone that involved a famous person going to jail for lying about getting an insider tip and so forth. So that's HER1. HER2, shown in blue here, is unique among all these receptors because it has no natural ligand. The ligand is the stimulant that binds the receptor. So typically, the receptor sits on the surface of the cell. It's like a baseball glove. The ligand is like a baseball, flies into the mitt, the mitt changes shape to capture the ball. And when it does, it sends one of those signals down into the cell. Don't die, keep growing. That's a very simple concept. There's a little more to it than that. But HER2 uniquely has no ligand. It's actually built spring-loaded and signaling already. Now, every cell in your body has HER2. There's no such thing technically as HER2 negative. The difference is HER2 normal, low-level expression, and HER2 positive overexpression. And those with overexpression have millions of copies of HER2 in each cell. And when that happens, they bump into one another and they signal, because the way they signal is banging into one another. So that's a simple idea. You know, Trastuzumab is the first monoclonal antibody. UMAB means humanized monoclonal antibody. Every time you see UMAB at the end of a drug, it's a humanized monoclonal antibody. The humanization means it doesn't evoke an immune response. If we gave you a mouse antibody, you would be allergic to it in 2 doses. But if we give you a human antibody, you're not allergic to it. That's the technical breakthrough. So Trastuzumab, very effective first-line transformed treatment, as you guys probably know, almost overnight in virtually speaking. And then more recently, a second antibody, Pertuzumab, brand name Perjeta, has been added to Trastuzumab. When it was given as a single agent, it wasn't that active, only a 7% response rate. But when it was combined with Trastuzumab, even in patients whose disease had already worsened on Trastuzumab, it had a higher level of activity. And that led to this chemotherapy-based trial called Cleopatra. Docetaxel, a taxane, was given with Trastuzumab alone or with the second antibody, Pertuzumab. The interesting thing here, just as a technical aside, is Trastuzumab binds low on the receptor near the cell surface. Pertuzumab binds high up, as if this was a tree. Pertuzumab binds the trunk, and Pertuzumab binds the leaves. So they're actually, even though they're both directed at HER2, they're different pieces of the receptor. And the result, again, was not only improved progression-free survival of a remarkable 6 months from 12 to 18, but also improved overall survival. And indeed, in our own series using weekly paclitaxel, we're at 24 months for a subset of these patients just for progression. And so there is no doubt that this has changed this disease. I'm not saying it's a panacea, it is not the cure, but this is a disease that used to be rapidly lethal. In fact, it used to be the worst subtype of breast cancer to have, and it's now pretty close to the best subtype. And the people who are on this, of course, once the 6 months of chemo ends, which is typical, have a pretty good quality of life just getting antibodies alone for now literally years. The new drug on the block, of course, is TDM1. Very simple concept. It's Trastuzumab, and the chemo is physically attached to it, so it delivers the chemotherapy to the cell. And I won't walk through the Amelia clinical trial except to say it was very positive, published in the New England Journal. And the control here was a standard treatment of oral drugs, capecitabine, that's Xeloda, and Lapatinib. So this was now the standard third-line therapy. You get your Pertuzumab, Trastuzumab, and chemo for 1 to 2 years, the disease gets worse, and you get TDM1. That's the current standard in HER2-positive disease. Overall survival was also improved here. You notice the theme for me. I always come back to survival, because when overall survival is better, it's a slam dunk that we're going to go and use it. When it's not better, you'll see intensive marketing and arguments about things, and I would tune some of those out personally. So I'm going to wrap up now. This is what I've tried to leave you with. Hormone therapy first for all ER-positive cancers with rare exception. Trastuzumab, not only first line for HER2 positives, but we probably never stop it unless you're on another research study. And that's been a breakthrough observation. Pertuzumab, if available, first line. I say the if available because around the world it's not always available. It is obviously in the US. TDM1 is what comes next, and you can consider Lapatinib and maybe even Neratinib, another inhibitor that's coming along very, very shortly. In general, we want to give one drug at a time in terms of chemo for metastatic disease. There is, however, no best therapy, and there's no standard role for surgery. I mention this because it often comes up in questions, why not operate? Radiation therapy, similar to surgery, is a local treatment for a specific problem. That's a judgment made by your doctor. This bone lesion needs radiation to make you feel better this week. It's not a long-term fix for anything, but it is palliative. On the plus side, I'm an optimist because what I showed you repeatedly, if quickly, is that the pessimists have it wrong. Overall survival can be improved. I showed you at least 3 or 4 clinical trials in the last 5 years where people lived longer. So when people say we can't aim for overall survival, you say, pooh, you can, and you should. There is, however, no overall standard and universal approach. That said, for the HER2 positives, there's a pretty well-worn path right now that is clearly associated with improved survival. But we're always focused on quality of life. We use site-specific palliation like bisphosphonates for bone mets as needed. Target agents are clearly the key to the future. Conventional chemotherapy development, I would say, has reached a bit of a plateau. Although they are not fully optimized, and we need to continue to study them, especially, by the way, for low and middle income countries. And one should always be looking for clinical trials. I say many good trials are available. That's true, but not as true as it could be. As a parting shot, I'll point out that the federal research budget through the NCI for all of cancer is 0.1% of the federal budget. And so a disease that overall affects a third to a half of Americans garners $1 in 1,000 at the federal level. So whenever people talk to you about the big war on cancer and all the research, the response is not, yes, it's frustrating. The response is, what war are you talking about? We've made a trivial investment. $5 billion a year at the NCI is not a lot of money. I know I'm from New York and you may think I'm jaded, but I'm telling you it's not a lot of money at all. We spend much more than that advertising soft drinks every year. We spend much more than that advertising cigarettes to underage smokers, $13 billion, for example. We spend that in a week or two every time we decide to bomb somewhere. And so it is just not the case that we can't afford it. And I will confess to you, I go to Congress and talk to them, and I don't understand on both sides of the aisle what they think this is. To wax just a little bit patriotic for a second, the reason that there's American leadership in the world is science and technology. This is the real source of American exceptionalism. Even patent protection was enshrined in the Constitution from the beginning of our country. I know I sound like a crazy person, but listen, this is why we lead. And what we are doing in Congress right now is electing to give up that leadership by not investing in science and technology. And it hurts us acutely now, and it hurts us as a country in the long run, and I have no clue why anybody thinks this is a wise decision. Anyway, thanks very much. I'm not frequently invited back to the congressman's office.
Thanks so much, Dr. Hudis. And for those who are interested in this issue, Living Beyond Breast Cancer and the Metastatic Breast Cancer Network have information that we can give you about how to get in touch with your representatives to ask them to put more money in the budget. So if you are interested in that, ask me about it, and you'll certainly be hearing about it through email.
So if you do that, I want to point something out. The budget's been $5 billion for 10 years. That's a 25% loss of purchasing power. I'm sorry, over 10 years. So keeping the budget fixed, which we've considered a little victory, is not acceptable. It's a loss of purchasing power, and it's a gradual ceding of our giving up of our pace of advance and development. So that's the first thing. And the second thing is, when they ask you, because they ask me this all the time, what should we cut? The answer is, that's not my job. I'm not interested in battling it out between this and school lunch programs. That's insane. Their job as leaders is to figure it out, but they also need to see that this is an investment in the future. Every dollar spent in any local community in NCI, NIH-supported research has a 2.4 multiplier in terms of local economic growth. So apart from anything else, the whole cold hard facts are that it makes the economy grow. And yet, that's not where we're putting it. I just don't understand it. You can tell I'm frustrated.
So everyone, you can see we have about a half an hour for questions. You can text them to
earlier.
me.
You said 45 minutes.
You were perfect,
All
Dr.
right.
Hudis. And if you can't text or don't feel comfortable, you can raise your hand and we will come and give you the microphone.
Oh, I see.
Thank you, Dr. Hudis. Is this on? Fabulous talk and incredible perspective. 2 questions. Can you talk about the status? Of immunotherapy research,
Yeah.
particularly PD-1 for metastatic? And the second question is, can you talk about the status of research for looking for receptors on triple negative so that targeted therapies can be developed?
So 2 great and timely questions. Let me give a little bit of extra background. So from the beginning of my career, there's been a popular perception that cancer in general and breast cancer, among others, was somehow a consequence of a defect in the immune system. I'm going to start by saying that is actually not true. The immune system has no meaningful role day to day in the course and outcomes of breast cancer. That's the first problem. The second problem, which gets more narrowly to your question, is that when you mess with the immune system, it's like poking a beehive, because the immune system is hundreds, if you will, of systems, plural. They are finely tuned and regulated, and I'm just going to give you a couple sobering examples. Lupus, ulcerative colitis, and even seasonal allergies all represent overactive immune systems in a general sense. So this idea that you want to rev up your immunity is false and in fact harmful. There are lots of quack products that are sold to rev up your immune system. It's nonsense. It will hurt you if it works, and it won't work. So that's the background. Now, in the last few years, in a more targeted way, it has become possible to control components of the immune system. The first of these was an antibody called anti-CTLA-4, and the second generation of this are the receptors called the programmed death receptors, and then the programmed death receptor ligand, PDL. And the companies going after a sort of a high-risk, high-yield area went after melanoma primarily first, because there's no real standard therapy for the disease, and it does so poorly. And Jed Wolchuk and others have proven that in melanoma, if you unleash the immune system in a controlled way, you improve outcomes. So the model that's frequently used is that the immune system's got all these fine balances, and if you rev it up a little, it immediately slows itself down because of the diseases I just described. You don't want an overactive immune system. But under the right conditions, we take the brakes off and let it rev up a little bit. So the anti-CTLA-4 antibody does that. And stimulating against melanoma and doing that has yielded some benefits. Similarly, PD, the programmed death receptors, in a very simplistic way, are a way for cancer cells to evade immune surveillance. And so fundamentally what this does is allows them to look more like normal cells than not, so they don't get picked up and identified as foreigners, and they therefore don't get targeted. And the drugs that are being developed there, PD-1 inhibitors and PDL, so forth, really enable them to become more visible to the immune system and therefore to be targeted. I'm simplifying, but this is a way to understand it. So what's happening? Well, we actually have randomized trials in breast cancer testing this, because that's the only way to figure this out. And we have a few specific observations. One of the weird things that happened in melanoma and in lung cancer, and I'm forgetting which the example was, but a patient who was on one of these immune therapies and doing well, stable, had disease progression just in the brain, got radiation to the brain lesion got better, and then a few months later, some of the peripheral lesions also improved. And the takeaway, which matched something we had seen in animal experiments, was that if you kill the cancer in place and release some of its targets to the immune system, it can rev up, and those same targets, of course, will be present on the distributed cancer. So that led us to the following completed experiment. We actually took people with early stage curable cancer planning mastectomy, and we froze their tumors in place with a freezing probe, but we didn't remove them at first. We gave ipilimumab, and we measured their immune responses, and then took them to the OR where they had their pre-planned on-schedule mastectomies, so we could study the breast and the specimen for immune infiltration. And it's a really exciting preliminary result showing that we can turn on the immune system. We have brain metastases and metastatic trials running right now, planned and running, I should say. And so it's very, very early days. I am enthused about this much more than I ever was about vaccines. Some of you may have heard me make some, cautious comments about vaccines over the years. The advantage here is we can stop these drugs. So if you get into trouble, you can turn them off. The danger of a vaccine, in a simple sense, is once you're vaccinated, and if it has consequences, what do? I mean, side effects. So that's where we are at the moment. I am cautiously optimistic that this will represent a meaningful palliative benefit in the medium term, But again, I do want everybody here to be very sober about this. If you start doing this, if we start doing this, people get sick with these drugs. Serious diarrhea, serious endocrine effects, and pneumonitis again, and so forth. So, you do not seriously mess with the immune system casually. That's the long answer to your question. And about I mentioned the androgen receptor for triple negatives, and right now the great hope is that by doing intensive sequencing, DNA sequencing of as many tumors as possible, that we will identify vulnerable pathways to target in these cancers. But it's a multi-step process. First, we have to find out that there are these definable subsets. We have to have drugs. The drugs have to actually pharmacologically work, get to the tumor, penetrate the cells, be effective, and then we have to show that they're tolerable and that they're going to have long-term benefits. And I mention that because that's where we are with a whole lot of targeted therapies right now. There are, 4, 5, 6 PI3 kinase inhibitors in development right now, maybe more. There are any number of drugs that are in development, and they all have to go through this gauntlet. There's no shortcut right now.
So I'm going to take one of the text questions, and then if there are other questions people wants to ask orally, just raise your hand and Nicole will come get you. Dr. Hudis, one person is asking, why do we run therapies until resistance develops and treatment fails? Why not stop sooner, change treatment, stop again before resistance develops, and cycle back and forth? Wouldn't we live longer?
Well, that's a science experiment. It's been partially, but not fully done in the past. So the Europeans, who have historically been more cost sensitive and maybe more sensitive to quality of life, have always taken, or at least historically took, a more conservative approach to palliative chemotherapy. And what they typically did, and you still hear this, is they would pre-plan in the face of metastatic disease to give 4 months or 6 months of chemotherapy and then stop. It sounds a lot like adjuvant therapy, and it's very confusing. Because what we would say is we're going to put you on therapy and use it until it fails, which is what the question addresses. And there have been randomized trials of those two strategies up front, and they show essentially no difference. The way you interpret them has to do with quality of life. So, for example, with a toxic drug like doxorubicin, those 4 or 6 month studies compared to continuous treatment show that you may as well stop at 4 to 6 months. You have less heart failure, fewer days of low blood counts, hair can grow back a little bit. When the disease does progress, you restart the doxorubicin, and the long-term outcomes are the same. Take a non-toxic or less toxic drug like, capecitabine. The study hasn't been done, but one might posit that a person emotionally feels better on active treatment, and their side effects are so minimal that the fact that they're doing something gives them comfort, and still there's no real difference between interrupted or sequential, or rather continuous therapy. So for the narrow first question, should you just stay on treatment till disease progression or stop sooner, we have the answer, and it doesn't actually make a difference beyond a few months. The more complex question, which I mean, designing this study would be a real Herculean task, is would you arbitrarily or randomly or logically somehow cycle therapies to beat this the emergence of resistance? And boy, I'll tell you, I would think that the complexity of this would make it undoable as a trial, because the tumors develop or have inherent resistance at different rates. They either develop it along the way under selective pressure, like bacteria with antibiotics, or the resistance is there from the beginning, but it's a small clone that, as you kill off the big sensitive clone, is left behind. I think it's a really big challenge. And my prediction to you is that such a study would be negative. That is, that in the end, all the strategies would be about the same. But I don't know. I mean, it's not a crazy question. It's just a daunting task to try to do it.
Thank you, Dr. Hudis. I think we had another hand in the air.
We do.
As a stage 4, and you've been offered a clinical trial, your first reaction is you don't know whether you're in the blind or in the actual study. Do you actually, if you're in, do you actually get treatment, or is it all a placebo? Because I think that's the confusion among me and my friends.
So I can't answer the question in a definitive way because I don't know what study an individual has been presented, but let me talk a little more broadly about this because this is a source of a lot of confusion. Let's take a disease for which there is no standard therapy. In that setting, it would be considered ethical to randomize a new promising treatment against a placebo because you want to see if the new treatment does anything at all. However, take a disease like breast cancer, for which there are many, many standard therapies. There is no clinical trial that I know of or ever heard of in my career over the last 30 years where the control arm got placebo alone. Doesn't exist. So many of the studies I showed you that were randomized had placebo in them, and this may seem confusing at first. No, everybody on the the exemestane everolimus study, everybody got exemestane. That is the standard hormone therapy for this setting. Half of the patients got a second pill that was placebo. Half of the patients got a second pill that was everolimus. But 100% of the study participants got the aromatase inhibitor exemestane. Ditto when we did docetaxel and trastuzumab. Half the patients got a real injection of pertuzumab, a third drug, and half got a placebo injection of saline as the fake third drug. Now, this is a really big issue, and we need partnership on this. The reason we do this is that most of the drugs we're developing are not so clearly transformative. They're incremental. And under the enthusiastic eye of patients and doctors, the bias is always to find the new drug is better. So, for example, in non-randomized phase 2 clinical trials, and I'm going to talk a little bit about this later this morning, it is typical to find a high response rate and a long time to progression and have the world hyping some new treatment, and then to see it not work out in phase 3. It's not that I don't want it to work out, but we have to be intellectually honest, and this is a big problem. So now anecdotes. In my career, I started off in the very beginning of my fellowship doing GI cancer, and my very first clinical trial was a randomized clinical trial in metastatic pancreas cancer, which in 1988 was a bad disease and is still a bad disease, right? Okay. So I did a randomized phase 3 trial of 2 different chemotherapy regimens that had been developed at Memorial. And this is a sobering truth. There were 80 patients on this study, 40 per arm. There were 3 responses on one arm and 2 on the other. Pretty bleak, right? But the phase 2 study that informed the exciting research arm of that trial had a 40% response rate and was published at ASCO with that. The investigator wasn't lying. He wasn't calling a non-response a response. Everything's scrutinized. But the selection of patients to go into the phase 2, maybe the unconscious elimination of the sicker patients, maybe the unconscious elimination of the people with more sites of disease. I don't know. Bias creeps in. We see it all the time. Now I'm going to bring it home to breast cancer. Iniparib, which was the failed alleged PARP inhibitor of about 5-6 years ago, was given in the phase 2 setting along with chemotherapy, gemcitabine and carboplatin, or a placebo, or maybe no treatment, I can't remember. But everybody got chemo. And it was such a promising phase 2 result that it got published in the New England Journal, big editorial, and we thought this was the beginning of the PARP inhibitor era. The phase 3 trial came in and failed. And I'm not happy about this. This is a setback. But it's a reminder that we need to have well-constructed, unbiased phase 3 studies to really know if things are transformative. Now, not always. To give you one more anecdote, when Gleevec, the drug for chronic myelogenous leukemia and GIST, which is a rare GI sarcoma, was developed, it didn't need a randomized trial because the curve with that drug was so dramatically different than anything ever seen before that it would be almost unethical, if not clearly unethical, to do the randomized trial, and it really never had to happen. But that's dependent on a massive signal. And such things do happen, but not all the time. So for modest but important incremental improvements, we need randomized trials. And this is a long answer. Here's a short answer. Everybody should be trying to get on a clinical trial every time. In breast cancer, You know, the problem isn't the placebo. The problem is that the experimental therapeutics may not be so great and may have side effects. That's the problem. But we don't learn if we don't participate.
Thanks, Dr. Hudis. And a lot of you are asking really wonderful questions about clinical trials. We'll get to some of them. If we don't get to all of them, Dr. Hudis is actually going to be speaking about clinical trials in the next metastatic session that's right back here in this room. So we hope you'll join us again. I have to check,
Okay.
but I will tell you before the break. So here's a question that we get pretty frequently, often from people with triple negative disease, which is, do you recommend getting gene sequencing? Is that something that's ready for the clinic?
So I want to make sure about semantics. Gene sequencing means testing the tumor. That's called, if you remember your Greek and Latin, soma, the body. So there's somatic changes and there are germline changes in DNA. When we test the tumor, that's somatic. And you can send your specimen to one of several commercial companies now, and they will sequence the DNA from the tumor. Most of them, not all, have a technique where they subtract whatever they see in the germline. So they do not typically identify inherited abnormalities like BRCA1, because that would be seen in the germline, your circulating blood cells, and in the tumor. Therefore, they would say the tumor is the same as the rest of you, and they wouldn't find that. But what they're looking for are variations, alterations, and changes that have been acquired in the development of cancer. And there are lots of them. So it makes sense to do this at first blush. The problem is the next step. Today, in 2014, unless you are participating in a clinical trial, there is no next step. And I pause for a minute because I want to make sure that sinks in. It makes so much sense to sequence the tumor. It seems so logical. It is commercially available and legal and billed to insurance. But there is no doctor right now who can use evidence to derive the treatment that follows from that result. So the only reason to do that sequencing of the tumor is to sort patients into appropriate therapeutic trials of targeted drugs. And that's what we're doing. But I will be very honest with you, at Memorial, where we do this, we don't charge for it. And that's because of what I said. It's a development phase project right now. We have an obligation societally that we take seriously to prove the value. And so be very, very wary of this. There's a lot of it going on. And, you know, it may not break the healthcare system, but it's just another example of the reach exceeding the grasp. Now, I want to answer the question a second way. If you have a triple negative breast cancer and you're young, you should at least talk to your physician about germline testing for BRCA1 and 2, and maybe PALB2, which is the partner and localizer of BRCA2. And the reason for that is that not everybody's family history is accurate, not everybody knows everything that happened, and in young people with triple negative breast cancer, there is a greater than expected chance that there's a hidden BRCA mutation, which, while not actionable today, A, might be when a PARP inhibitor gets approved, B, could lead you to an appropriate trial, and C, has tremendous familial implications. And you're going to see, if you haven't yet, that there is an increased attention to the idea of germline testing anyway. Mary Claire King, who just won the Lasker Prize for work she did with Efrat Levy in Israel, suggesting that our high bar for genetic testing of the germline may in fact be too high. So you're going to see some of the discussion going on in the coming weeks on this issue. But I want to draw a very clear distinction between testing the tumor for its acquired genetic abnormalities and testing the person for their inherited genetic variations. Two different things, easy to confuse.
Thank you. Kind of following up on that, does the tumor change over the years? And is it a good idea, and if so, is it a good idea to get a rebiopsy and a reanalysis of the tumor?
So I think it will become so. Right now, the only reason to do a biopsy is, one, to establish the diagnosis. It has happened to every doctor you know. Patient has breast cancer, develops bone lesions, it looks like breast cancer. You do the biopsy, it's myeloma. They had the bad luck to just get a different disease. This matters. So that's the first reason to do the first biopsy always. The markers changing, that's a tricky issue because the only markers that matter are ER, PR, and HER2. And losing them as you become resistant to therapy doesn't really much matter since you're already resistant to the therapy. Gaining them is rare, and much of the alleged change is honestly laboratory variation, not real biology. And so it's hard to justify this as a routine thing because, again, like the genomic testing, there's no next step. Doing it for genomic testing reasons, yeah, we're hugely enthusiastic about this as research because we want to know what happens over time under the pressure of treatment. And so we have clinical trials where people allow us to do repeated biopsies. But again, you know, I may sound a little overly rigid, but there's a big difference between what we do as research and what should be considered as standard. Our patients who are doing this, honestly, are helping everybody in the world, but they're not really helping themselves in any tangible way yet. So maybe someday we'll need to do sequencing sequentially, but we're not there yet. We don't need the first sequence routinely yet, and we don't have a need for the next one either. You know, just to introduce, just to not confuse you, but maybe concern you, there were a couple of beautiful papers the last few years using this technology in various ways. One study by Charlie Swanton's group from the UK published in the New England Journal. They took, I think it was 4 patients only with renal cell cancer, and they sequenced their tumors from various metastatic sites. So they were able, on the one hand, to build a cladogram, which for those of you that go up to the Museum of Natural History in New York, you know, the cladogram is the tree of how the dinosaurs evolved, and you walk the floor, you see the branching and all that. So they're able to reconstruct the evolutionary tree of that person's tumor. But the sobering reality was that there are variations in the genomic changes in the tumors at the same site, depending on whether you were, you know, 9 o'clock or 3 o'clock in the tumor. So just think for a minute about how we're going to accurately integrate the many clones that might be present and identify the noise versus the signal, because some of those variations and mutations are just junk. They're not meaningful, and others might be the drivers. So I'm humbly submitting to you that it's early days.
We have a couple of people who are asking for your opinion on palbociclib.
Oh, yeah, I'm very excited about the drug, but we'll see. So this is a CDK4/6 inhibitor. It's the first of at least 3 drugs that are in development that target these checkpoint inhibitors. Again, I'll give you the very simple science. So the cell has these ways of stopping itself from dividing and duplicating when it detects a defect. It would be kind of like, in a very simple way, if your email program doesn't let you hit send when there's a misspelling in the text. But what you kind of want in some cases is to unleash that block and allow the cells to go on to divide and die. And again, in a very simple sense, if you inhibit the checkpoint inhibitors, then you might be able to allow that to happen. So this is the first drug in the class, and it had a very promising phase 2 result. There's an echo of the question before. It was presented over the last 2 years in very high-profile meetings. Very, very promising, not survival, but dramatic improvement in progression-free survival when added to hormone therapy. And there's a reason for that. There's a biology that says that estrogen receptor positive cancers will be more dependent on this particular pathway. And so they have filed for accelerated approval, and I've heard rumor that it'll be reviewed in January, February by the agency. For those of you who don't know, now we're in regulatory discussion, but accelerated approval is a funny term. What it means is that the FDA has lowered its already low standards for cancer drugs. I choose my words carefully. There is no other area of drug approval where the standards for new drug approval are as low as they are in cancer. And there's a reason for that. I'll come back to it in a minute. But they relaxed them even lower on the condition that after approval, the sponsor will develop additional data to support the label. That's the bevacizumab story. I'll talk about that in the clinical trial session a little bit. So they have filed for accelerated approval. It's like a no-risk gamble in the sense that if they lose, they're in the same position they were in anyway as a company. But if they win, they get over. It's palbociclib, and it's a CDK4/6 inhibitor. So that's the story there. The comment, since I alluded to this, that you should understand is that for any drug that gets approved in the U.S. into the marketplace, there's an assumption that virtually any licensed physician might be prescribing it. So a pain medicine, an antihypertensive, an antibiotic, they have to be safe for broad use. There's actually a tacit understanding that cancer drugs will only be prescribed by oncologists. And so the agency tolerates a whole lot more toxicity and a lower level of effectiveness, a narrower threshold, or rather therapeutic window, in cancer drugs than anywhere else. I mention this because the agency gets a lot of bad rap, and it's not really deserved. Their standards are really low. Only in cancer do they approve drugs with just phase 2 data. They would never do it in any other setting at all. Only in cancer do they do it without a confirmatory trial. They've approved more drugs in the last 3 years in cancer than in the USA than in anywhere else in the world, and than in any time in history. So I say all this because I think there's a kind of an anti-FDA rant out there occasionally. And honestly, if you ever had to sit in a seat and make decisions about drug approval, your eyes will be opened up very quickly about the risks and the harm. Remember, they're screamed at when somebody gets hurt. They're screamed at when a drug gets pulled from the market because it long-term didn't work out. And then they're screamed out because they didn't release it in the first place. It's kind of a no-win.
So I'm going to take one last question, and unfortunately we're going to have to take our break. One person is asking why we do not study people with metastatic disease who have 5 years or more
We do.
with no evidence
So
of disease.
We study everybody, and there are 2 ways this is happening. It's a great question because just 2 days ago, I think, or maybe it was yesterday, I can't remember, the NCI sent out a broad email pointing out that they are now sponsoring a so-called outliers study. An exceptional case study. And what this means is that if we as physicians have any patient on standard therapy, forget about research studies, who appears clinically to be an outlier, somebody got doxorubicin and their cancer seemed to really disappear and never come back for 5 years, the agency wants to, or rather the NCI wants to know about them, and we want to study them every way that we can. So there is that exploratory kind of study. That's not going to directly answer questions. What that's going to do is ask them. That's going to provide material that says, what was different here? Is it exploitable? Is it recurrent? Is this the only human where it ever happened? Or are there 100 cases like this, or 1,000? And we don't know yet. So that's the first answer. The second one, I'm sorry I have a long answer here, is we're poised to be able to do something in medicine that's very different than we did in the past, and that brings us up to the modern era. So let me ask you a question. How many of you shop on Amazon? How many of you have a Facebook account? And how many of you ever use Google? Okay. So all 3 of those examples are pure electronic or digital media where everything you do is tracked, right? You know that Google's gotten so smart that as you're typing in the search box, it's already filling in suggested searches. Just think about the derivative order here. They're not just waiting for you to tell them what to search for. They are making a pretty good guess about what it is you're searching for first. And then they're delivering the results to you. Why? Because they have essentially studied every single search for the last 20 years now, and they can make a pretty good prediction. As an aside, somebody who was in Google, who I met with for a different reason, made this idle comment to me: why do you think Google invested in Uber? They want to know all the routes that everybody drives because it's going to inform their self-driving car programming, right? So then turn your attention to medicine. We write with pen and paper and we store in filing cabinets in 1,000 locations around the city, let alone the country. We never aggregate the data. We don't see patterns. We don't see reproducible outcomes. We don't have any idea what happens to 97% of people, adults, with cancer. Now that's changing, or at least it could change, because 60 to 80% of all cancer care is now being rendered finally in the context of an electronic medical record, which means, all else being equal, we can start to aggregate this data and maybe start to learn from it. I want to be clear about this. It will never replace clinical trials. There's bias in what doctors do. That bias will be reflected all the way through the outcomes. On the other hand, we might start to see some of the associations with these outlier responses, again, that we could start to exploit. And the program from ASCO called Cancer Link is an attempt to do this. We're trying to draw data in from every different EMR. One of the problems in the US is we don't have exactly a common language. All the EMRs are proprietary so that they don't talk one to the other. That is solvable, but it's very expensive to solve, and we're working on that now. So my answer is, great question. We're beginning to have the tools to be able to do this for the first time, and indeed we are starting.
Thank you so much, Dr. Hudis. Please give him a hand. And I want to thank all of you. You have wonderful questions, and I'm sorry we weren't able to get to all of them. We are fortunate that 45 minutes from now, Dr. Hudis will be back in the clinical trials session where we'll be talking about how to get involved in clinical trials and some of the open trials that are open now. For the next 45 minutes,